Greetings and welcome to the module on therapeutic communication and therapeutic relationship. Therapeutic relationships include key concepts in which the relationship includes the milieu, which is the setting within which nursing care occurs. The focus of the therapeutic communication is on the needs of the individual, family, group, or population. Key components of the nurse-person relationship include knowing each other, reciprocity, mutual respect, and confidence. The therapeutic relationship between the nurse and the individual also extends beyond the individual to families, groups, and populations. Health promotion and helping relationships include requisite skills and attributes such as interpersonal skills, insight, accountability, and especially values clarification. Let's look at values in the therapeutic relationship. Values include the qualities, principles, attributes, and beliefs about the worth of the person as an individual or group. Such values guide nursing actions. Values are embedded in the culture, including the family and social context. Types of values include active values, where a person physically acts on their values, and cognitive values, which include verbal and intellectually expressed concepts. Values evolve over time and are affected by life events and social processes. Values clarification is an important beginning step for the nurse when working with individuals, groups, or populations. Values clarification is one method for discovering one's own values and the importance of those values. It is essential to the interaction process to do a self-evaluation of one's own values because they will shine through in our interactions with others. Values can occasionally conflict, resulting in ethical dilemmas. The 7 steps of values clarification include choosing freely, choosing from alternatives, choosing after careful consideration, cherishing values, public affirmation, acting the choice, and repeating the pattern. The therapeutic use of the self is the application of one's cognitions, perceptions, and behaviors to create interpersonal encounters that promote health. This can be with a person, family, or group, and the community. Aspects include self-concept, which is a mental picture of the self evolving throughout life and shaped by genetics, experiences, individual actions, and feedback. This also includes an individual's self-esteem, learned from experience and resulting from feedback, abilities, and limitations. Steps in self-awareness include listening to oneself, paying attention to the emotions and thoughts we experience, and memories which come and reactions to experiences. This can result in self-reflection. Listening to and learning from others' feedback provides important information for reflection. And then self-disclosure, the appropriate sharing of self, which can enhance self-knowledge and promote reciprocal interaction. Practical reflection is reflection enhancing the understanding of events and corrective actions. So the communication process then is the form for all shared thought. It is a tool for health promotion interventions and provides the foundation for the nurse-patient relationship. And it includes information exchange between individuals. Patient-centered communication is intentional, attentive, caring, empathetic, friendly, comfortable, calm, interested, sincere, and above all, respectful. It is the cornerstone of the nurse-patient relationship. Communication function and processes. Communication function is divided into core functions of communication, including obtaining and sending messages and retaining the information, the use of information to draw new conclusions, revisiting the past and anticipating the future, beginning and modifying physiological processes, such as what occurs in psychotherapy, and influencing others and events. Processes of communication include input, taking in information, output, further information exchange, feedback, which is monitoring the system for communication, which can be either positive or negative, and the situational context, which is physical, psychological, psychosocial, and cultural. In the diagram, you can see a fundamental breakdown of communication in its interactive phase. Verbal and nonverbal communication also needs to be attended to. Verbal communication includes both spoken and written forms of communication, since words are symbols for ideas. This can include sign language, braille, and touch language. Communication with language is a critical ability. Challenge of communication can occur when we have language differences. The functions are to inform, to trigger response, and to describe. Nonverbal, which includes gestures and facial expression, are messages which are not spoken or written. These can include facial expressions, eye movements, and body movement gestures. These are particularly vulnerable to misunderstanding because they are culturally and situationally bound. There's great power to transmit information, including thoughts and feelings, with nonverbal communication. Nonverbal messages occur from both the patient and the nurse. Let's look at MetaCommunication. This refers to the meaning behind a message. One cannot avoid communicating, as communicating is inevitable. But reading between the lines is gleaning nuances of meaning. Relationship aspects of communication are a component of MetaCommunication. These convey the unstated meaning. The nurse will note that content, which is verbal, may sometimes be incongruent with the nonverbal communication. These incongruences can leave the receiver uncomfortable and confused. Patient-nurse perceptions of nonverbal meanings are an important component of MetaCommunication. Then we turn our attention to group process. Group process is a rather advanced concept and includes special types of MetaCommunication which occur in group settings and are called group processes. This can include group psychotherapy, but also meetings or other groups, and include group theory, which holds that all communication has both content and process. All meetings involve group processes. Emerging patterns within group dynamics occur, and particular patterns may be counterproductive. Therefore, the group leader assists to interpret the process and resolve problematic patterns. Let's look at effective communication steps. The first is firmly stating a case. The need for congruent content and communication. Clarifying the message includes the need for a complete message, for example, using I statements. Seeking feedback is another form of effective communication, which provides validation and confirmation of communication. Being receptive to received feedback is another component of effective communication and facilitates functional communication. The factors involved in effective communication include listening actively, which is a significant intention, focusing on what message is being conveyed. This can include nonverbal cues, which are influenced by the culture and situation, and also reciprocity. Flexibility balances control and permissiveness and fosters adherence to rules of appropriate communication. Silence can be used in a therapeutic way, but it sometimes can convey a lack of interest versus a reflection time to consider what is being said, and can convey support. So this image says the biggest communication problem is we do not listen to understand, we listen to reply. And stop and think for a moment about how often that happens in casual communication with people. Additional factors in effective communication that should be ineffective, not ineffective, include the use of humor, which from a positive perspective can relieve tension and share a climate of comfort, but from a negative perspective can block communication and inflict emotional pain. The use of touch can express concern, but sometimes may be perceived as inappropriate and threatening. And finally, considering the space between the communicators. This varies according to the type, setting, and cultural context. Proxemetrics includes the 4 zones of space, and understanding space will enhance communication congruency. So let's turn our attention to health literacy, which we'll go over in more detail later in the course. Health literacy is the capacity to read, comprehend, and follow through on health information. The key factors to be considered include the educational level of the target audience, the reading and comprehension level for the materials, and understanding the native language of our target audience. So in preparing health information, we should attempt to keep the information at the 5th or 6th grade reading level. That's the goal for providing written information to patients, and avoiding complex terms and medical jargon, using 1 to 2 syllable words, and simplifying sentences to avoid multiple phrases that can be confusing for someone who does not understand medical information or where English is a second language. Now, we turn our attention back to the therapeutic relationship characteristics. This is where one person promotes the well-being of another. It's purposeful communication, which is goal-directed and is based on development of a rapport and a sense of trust, a reliance on another based on a sense of safety, honesty, and reliability, facilitated by clear relationship definitions and being consistent. The characteristics of therapeutic relationships include empathy, the ability to understand others' feelings without losing our own identity and perspective, and having a personal understanding while maintaining appropriate boundaries. Being goal-directed, which exists solely to meet the needs or well-beings of the recipient. Goals are measurable, focusing on change, which is short or long-term, and developed jointly by the nurse and patient when at all possible. Ethical considerations include that behavior affects others, therefore actions must involve choices that may be judged by the standards of right or wrong. The nurse is to respect the individual's rights and support the person and family's integrity. Confidentiality should always be protected by standards of HIPAA and FERPA. Therapeutic techniques, although this is not a comprehensive list, include focusing on the individual. It is the person, not the nurse, who is the focus of the interaction. Helping the person to clarify both content and meaning. This prompts further description and data acquisition, and the goal is to help the person describe the problem and solve it together. Reflecting in interactions includes selective paraphrasing or a repetition to verify that the person's or patient's are heard and what the nurse is saying, or that the nurse is reflecting what the patient has said. The goal is to emphasize, summarize, and elicit information. So therapeutic techniques also include constructive confrontation, which identifies behaviors that may be problematic and helps the person to examine the meanings and consequences of their behavior. This includes clarifying the patient's preferred nouns and pronouns and promoting clear thinking and communication. As mentioned earlier, silence can allow the person to communicate at their own pace and provides time for reflection. Motivational interviewing is a therapeutic communication which is person-centered, fostering behavioral change. We'll talk about that briefly in the next slide. Motivational interviewing is a person-centered communication approach to foster behavioral change. Key components include engaging to address issues and establish trust, focusing to narrow the focus to the area of change being sought, evoking to elicit the motivation for change, and collaborative planning to develop steps to create change. Training in motivational interviewing is available, and it can be learned and practiced by all advanced practice nurses, not just psychiatric mental health advanced practice nurses. Barriers to effective communication can include anxiety on the part of the sender or receiver, which can alter the perception and distort reality. Attitudes are also sometimes barriers, and these can include biases and stereotypes which can limit our ability to relate. Communicating negatively, which can further distort perceptions, can also be a result of these attitudes. Gaps between the nurse and the individual based on sex, age, ethnicity, language, and other differences have to be acknowledged and overcome, because they can cause differences in perception and block understanding. And then the concept of resistance being that behavior which can be enacted to reduce anxiety, such as avoidance and anger. However, the goal is to identify and interpret as well as understand the behavior of resistance. Additional barriers to effective communication include transference and countertransference. So transference is reacting to another person as if that person is someone from the individual's past. Countertransference is when the receiver begins to behave like the person the other individual is transferring their thoughts and feelings onto. The goal here is to understand the feelings and thoughts and remove any distorted reality that may occur. The failure to address the concerns and needs includes the goal to correct the source of failure, such as inadequate assessment prior to beginning. We also need to consider the settings in our communication to see if they facilitate or become a barrier to communication. These can include settings in which there is control exercised over the person, disturbing environmental factors that can also inhibit communication, such as noise or inappropriate places, or others being able to overhear what is being communicated between the nurse and the patient. Key components for brief interactions include that the goal must be realistic and clearly defined, that we must use manners to engage or re-engage the individual or individuals, including introducing oneself, orienting the family to the meeting focus. Assessing significant areas of internal or external structure and function is also an important component for brief interactions. So we should ask the family members the 3 key questions and commend the family on 1 or 2 strengths that they have demonstrated in the brief interaction, and finally evaluating the usefulness of the encounter, and then conclude. Another thing that we should be aware of is that relationships occur in stages. Therapeutic relationships tend to follow sequential phases, although the stages may overlap and vary in length depending on the issues that exist over time. Peplau originally discussed the stages of therapeutic relationships, but in their essence, there is first the orientation or introductory phase in which there is establishing the connection between the nurse and the patient, and then providing consistency and active listening while demonstrating concern and warmth. In the working phase, the nurse and the person partner to promote health. And finally, in the termination phase, the end of the therapeutic contract comes about, which can cause anxiety for patients. These stages can occur in brief interactions as well as in longer interactions. Thanks for watching this video recording of the Therapeutic Relationship and Therapeutic Communication.